Hi everyone, it's Diane here again, and I'm delighted today to be here with Mr. Nick Panay. Nick is a consultant gynaecologist and one of our leading menopause experts. I am very grateful to you for doing this today. Nick's time, I know, is taken up probably minute by minute, so we are really fortunate to have a little bit of his time. And what I wanted to do today was to essentially get some guidance for some of you who have more complex menopause cases because perhaps of previous medical history. So we're going to talk a little bit about a study that was started in 1993, prematurely sort of finished around 2003, 2002, that was the WHI study. I'm going to get Nick to talk a little bit about that, and then we're going to talk a little bit about what women who have had particularly gynae cancers and breast cancer, what their options are around menopause. So, Nick, could you give us a little potted history of this WHI study that caused so many issues, and also update us on, once that data was re-evaluated, what it really meant?
Of course, Diane. Thank you very much for having me.
Pleasure, thank you.
So the WHI was designed at a time when hormone therapy was very popular.
Yep.
About 30% of women were using hormone therapy. And it was designed primarily as a prevention study to determine whether it would be possible to reduce the cardiovascular risk of women.
Okay.
But in addition to cardiovascular benefits, other benefits were expected, such as reduction of fracture risk.
Mm-hmm.
But also the risk of breast cancer was
Yep.
being studied in this
Okay.
particular study. They were looking at a group of women that perhaps we wouldn't see routinely in our clinics. The demographic was a much older one.
Okay.
So only about 30% of women were in their 50s.
Right.
The others were in their 60s and 70s. And women as old as 79 were being given relative overdoses of hormone therapy.
Okay.
Or receiving the same dose.
Yeah.
Which was an old-fashioned type of preparation, which is still available actually.
Mm-hmm.
Called conjugated equine estrogens.
Yeah.
So I'm sure the viewers will be familiar with the mare's urine derived type of
Yeah.
HRT. Now, for those women that hadn't had a hysterectomy, they needed a type of synthetic progesterone.
Yeah.
And on this occasion, it was one called NPA, medroxyprogesterone acetate. Now, rather than showing a reduction in cardiovascular risk in the overall data, there was concern when the study was prematurely stopped in 2002 that what they were seeing was an increased risk of cardiovascular episodes.
Okay.
So coronary heart disease, venous thromboembolism, but not just that, there was also concern about a small increased risk of breast cancer.
Okay.
We were told at the time, and the media reported it as such, that the data applied to all age groups.
Right.
What we didn't realise at the time, and in fact this wasn't realised until 5 years after, when the subsequent analysis was done into age cohorts, was that the risks were almost entirely confined in the oldest age cohort, the 70 to 79.
Right.
And if anything, there was a trend towards reduction in cardiovascular risk in the younger cohort, 50 to 59, which is a group of women that we typically see in our menopause clinics.
Absolutely.
There was quite a lot of controversy as to whether there was or wasn't an increased risk of breast cancer. And the controversy actually still rages because it depends how you actually look at the data.
Okay.
But overall, there appeared to be certainly no more than one extra case of breast cancer per 1,000 women per year. And then at the final analysis of the data, what was really encouraging was that there was no increased risk of mortality either from heart disease or from breast cancer.
Okay.
And the women who received estrogen only actually,
so the hysterectomized.
yes,
Yeah.
actually had a reduction in risk of breast cancer,
Really?
around
Okay.
30%,
Okay.
as well as
We didn't see that report.
cardiovascular protection. No, you tend not to hear about these things. So where that left us was analysing why there were certain problems with WHI. Primarily, it seemed to be because women in too old an age group were receiving too high a dose of estrogen.
Right.
That initially was causing clots in the arteries and veins, but then
and was this oral, Nick?
It was oral estrogen,
okay.
Yes. And then as the study sort of went on, those risks reduced, but there was an initial increased risk in the older age cohort. The risks were not seen in the younger cohort to the same extent.
Right.
Now, but it wasn't just concern about the estrogen. We now believe that the type of progestogen which was used, which was medroxyprogesterone acetate, was certainly not the best type of progestogen, possibly the worst.
Okay.
Because metabolically it has an adverse effect on the blood fats,
right,
cholesterol, and certain what we call lipoproteins. It increases insulin resistance, which is not a good prognostic indicator for heart disease, and it reduces what we call arterial compliance, the flexibility of the blood vessels.
Okay, yeah.
So we've tried to learn from the lessons of WHI, and now what we're using is age-appropriate doses.
Okay.
So if we're treating an older age group, we give a lower dose of
okay.
estrogen. Many of our women are now receiving estrogen through the skin because that doesn't go through the liver, so that doesn't increase the risk of clotting, it doesn't increase blood pressure. And also from a breast perspective, it seems that if you go for a more natural type of progesterone, like natural, what we call micronized progesterone, the regulated bioidentical type of progesterone, or dihydrogesterone, which is the closest synthetic type of progesterone that we have to natural progesterone, then there's less of an impact on breast cell proliferation, so potentially a lower risk of breast cancer.
Okay, so with the, I mean, you know, sort of at the time, the headlines were very much about increased rates of breast cancer, etc.
Yes.
Could you sort of give us an update now as to what the sort of the current state of play is around the real risks rather than the headline risks?
Well, the bottom line is that if there is an increased risk from those data, it's a borderline increased risk. And when we did the meta-analyses, the subsequent analyses, when we formulated the NICE guidelines on menopause, as I say, we found that actually the real risk was very small indeed, less than one extra case per 1,000 women per year, that didn't become statistically significant for at least 5 years after the menopause transition, and was really only a statistically significant risk for women who'd used HRT prior to entering the study.
Right.
And as I say, I must emphasise that for women using estrogen alone, generally speaking, there doesn't appear to be an increased risk. And in the WHI study, the one advantage of the mare's urine type of estrogens is that they seem to have a protective effect on breast cancer, if anything. So, as I say, there was actually a decreased risk of breast cancer in the women receiving that type of estrogen.
Could you talk a little bit about the sort of current HRT preparation that we're hearing a lot about at the moment, which is the body identical type of HRT? And could you just once and for all, for everybody that's watching, could you just clarify this issue between body identical and the term bioidentical? Just so, because we get an awful lot of questions about, well, what's what, is it different, is it the same? So could you just...
It's very simple really, whether you use the term body or bioidentical, what it means is that the type of estrogen or progesterone that you're giving, or testosterone for that matter, is exactly the same as the hormones that the ovary would have naturally
produced. So it's the same molecular
produce.
structure.
Same molecular structure. The difference is that there are some which are authorised by the medical authorities, like the MHRA in the UK, FDA in the States, and there are some which are unauthorised or unregulated, which are typically made up in compounding pharmacies, supposedly to the specification of the individual user.
Yeah.
But the bottom line is that we all, in our practice as doctors, try to individualise the hormone therapy that we give.
Because they all come in different doses.
They come in different doses, they come in different routes, there are different types,
Yep.
etc. So we base our prescribing on someone's medical history, their family history. If we're not sure where we are in terms of their menopause transition, we might do a blood test, although it's not always required.
Yeah.
And yeah, we try to individualise it according to all of that and the goals that we jointly sort of try to achieve.
Yeah.
And my argument is, well, why go to unregulated preparations when you can achieve the same outcomes with regulated preparations that have been tested for effectiveness and safety,
Yeah.
and have many, many years of research behind them?
Yeah, absolutely. So one of the things that comes up very regularly are women who are told they can't have HRT for one reason or another. Quite often it's around weight or the fact that they smoke. Quite often those women are told, no, you can't have it. And I'm not talking about a complex medical history, but with generally, are there women who really should not be prescribed HRT if they're struggling with what we would describe as debilitating symptoms?
Yeah, I mean, my view is that we shouldn't make sort of arbitrary rules about these things. We certainly shouldn't put arbitrary limits on duration of use, which is one of the other sort of controversial areas.
Absolutely.
I believe that the way to achieve our goal, which is to maximise benefits and minimise risks and side effects, is to individualise hormone therapy. And also, the most important thing, I think, is taking into account a woman's wishes.
Yeah.
I always say that longevity means very little without quality of life. And many women suffer because they or their practitioners think that it's not possible for them to have hormone therapy because they may have, as you say, slightly high blood pressure or maybe slightly overweight or whatever. But actually, if you carefully weigh up their pros and cons, it is possible for them to have it as long as we tailor-make their treatment so that if we think that there is an increased risk of heart disease, for instance, because someone's overweight or they have high blood pressure, then we'll tend to go with lower doses of hormone therapy, giving the estrogen through the skin, giving metabolically friendly types of progesterone, etc., etc. And there may even be a benefit to them, using hormone therapy in that context. Although we don't prescribe it primarily for preventive purposes, it's primarily for quality of life purposes. But I think the NICE guideline was quite clear in saying that women who may have cardiovascular risk factors, but if those risk factors are well controlled, they shouldn't be denied hormone therapy. Yeah,
and I think that's really important, isn't it? That we do have those guidelines and they are very clear. It's just really a case of sort of getting them out there amongst all those practitioners to read, which I certainly hear all the time. We know how busy GPs are and there are guidelines on everything.
Yes.
But they are there and they could be referred to. And what I often say to people is, if you're coming up against a brick wall as far as having it, actually have the conversation and say, would you mind going away and referring to them, or even contacting, not necessarily you, but a colleague who perhaps runs an NHS menopause clinic in the area to ask for some advice. One
of my old colleagues, Professor Robin Touquet, always used to say, knowledge dispels fear. And I think that a knowledge vacuum was created by the WHO. So many doctors basically turned away from hormone therapy, and the education into aspects of menopause treatment, particularly from the hormone perspective, perhaps weren't what they should be. And that's partly down to there being an absence of enough menopause information in the curricula for GPs and for gynaecologists. you know, it's not just a GP thing.
No, absolutely.
And I would hasten to add that there are many very good GPs out there who are either experts in this area or have an interest, who are perfectly capable of managing menopause patients in a perfect way. But the problem that we have is that there aren't enough menopause clinics in the country for every woman to be referred, and that's why we do need to continue on our educational quest to get at least one GP in every practice totally engaged and totally up to date with the latest information on this subject.
Yeah, absolutely.
You know, and I believe that the British Menopause Society is making great strides in trying to achieve this. We now have over 150 menopause specialists around the country that have done either an advanced menopause certificate or have some sort of an advanced qualification, possibly from the Royal College of Obstetricians and Gynaecologists. We have the NICE guideline. We're working hard with the RCOG, and we're going to work with the RCGP to further education within this area. And I believe the time is ripe. I think that there is much more, thanks to people such as yourself and many celebrities out there who have started talking about menopause and demystifying it and making it acceptable to talk about it. I think this is going to be driven by women. I believe that we have a duty of care to these women to look after them to the best of our ability. And you know, as I've said to you before, I think if we invest a little bit of money now to enable every woman to have a menopause check, you know, not just to talk about HRT, but lifestyle,
health,
diet,
well-being,
exercise, stopping smoking, alcohol consumption, talk about HRT alternatives where HRT can't be used, then that sets them up for the second half of their life. You know, if it's not just about the individual, it's about them being able to give back to society as well. Personally in their relationships, in their social activities, and also in the workplace.
Absolutely, yeah. You know, I mean, personally, I'm seeing that. You know, I counselled 2 women yesterday who have both given up their jobs because of their menopause symptoms and because they weren't able to access anything other than antidepressants. So yes,
we need to get away from
it's
that.
Huge.
The automatic prescription of antidepressants in the menopause, which don't work and sometimes make the situation worse.
Yeah, absolutely. So, as I said earlier, one of the reasons that I desperately wanted to get a little bit of Nick's time was to talk about some of you who have had gynecological cancers or have had a breast cancer and are feeling very alone with your menopause symptoms. So Nick, could we go through, and I realise this is literally going to be touching on it, could we just talk about the 5 gynae cancers and what is possible? So we don't have to go into detail, but you know, sort of, is HRT something that could be considered, or is it an absolute no-no? And then a little bit about breast cancer, and again, very much an overview, but just to give sort of a few sort of hints and tips to those women about what it is that might be possible for them and where it is they would perhaps need to be asking to be referred to, etc. So the most common question we get around gynae cancer is around womb cancer. So obviously these are women who have had surgery.
I think the easiest place to start is with vulva, vagina, cervix cancer. No contraindication to using hormone therapy. Okay, so easy.
That's easy.
Now,
thank you.
Can I just preface this by saying that cancer, according to the information leaflets and the pharma companies, is a contraindication in these circumstances. But we're now talking about women that have a need which we need to address, which is maintaining their quality of life after the excellent treatment that oncologists have.
Yeah, that's exactly it. This is very much about quality.
For ovarian cancer, jury's out. The data that we have so far from a couple of randomised trials, from the meta-analysis, the subsequent analysis data, look encouraging. That being on HRT doesn't increase the risk of recurrence, and in fact, in some studies, it seems to actually reduce it. There was a Marsden study, and reduces mortality as well.
Okay.
But we still have to be cautious and still individualise and weigh up the pros and cons according to, how much that individual is suffering, what their other risk factors are, what the actual findings were with regards to the pathology of the tumours, etc. But making, a balanced choice for that individual. In terms of uterine cancer, it appears that if you treat women with hormone therapy with early stage uterine cancer, so stage 1 or up to stage 2, there's one randomised trial, there are meta-analyses suggesting that you don't increase the risk of recurrence.
Okay.
We don't have clear data for the more advanced cases, that's where we do need to be cautious. There would potentially be an increased risk of recurrence, but for the early stage, it's not necessarily contraindicated.
Okay, and for all those women you just mentioned, would you feel that those women should certainly be being referred on to
I wouldn't expect
the Menopause Society menopause specialist,
the average GP out there, or the average gynaecologist necessarily, to be prescribing under those circumstances.
So somebody that didn't have specialist knowledge.
Absolutely, I think it should be within the domain, at least in terms of the initiation of treatment.
Okay.
In terms of breast cancer, the jury is out again. One of the reasons being that because of the WHI, a number of the studies that were being performed at the time looking at the impact of hormone therapy on breast cancer recurrence were terminated early.
Okay.
So there were a couple of Swedish studies. There was one called Habits, another one called Stockholm, and there was the Marsden trial in the UK. The Marsden and the Stockholm trial were not showing an increased risk of recurrence, whereas Habits was. It may have something to do with the fact that more women were using tamoxifen in the studies that didn't show an increased risk of recurrence, because that does seem to have some protective effects. So if you've got somebody who's on tamoxifen that wants to use hormone therapy because they've tried everything else and nothing's working, then we feel more comfortable about prescribing if they're on tamoxifen. If they're on an aromatase inhibitor, it's absolutely pointless them staying on an aromatase inhibitor and having hormone therapy, because the way they work is by basically reducing the presence of estrogen in the body to virtually zero. But I think the take-home message really is that if somebody is suffering and they've had a past history of cancer or any other contraindication to hormone therapy going by the book, then they need to see a specialist to discuss whether it's something for them. And also we mustn't forget that there are alternatives to hormone therapy, pharmacological options like gabapentin, which is a pain drug, venlafaxine, which is an antidepressant, oxybutynin, which is a bladder drug, that can also be used to alleviate vasomotor symptoms, so hot flushes and sweat. Maybe not as effective as HRT, but if you take the edge off these symptoms, it enables women to sleep and have some break from their symptoms, absolutely. We're also doing some really interesting research at the moment looking at something called neurokinin antagonists.
Could you explain a little bit about that?
Yes.
Because I said because I've heard of it, but everybody else won't have done.
So basically there are neurons in the hypothalamus, lower part of the brain, that fire off signals that basically result in menopause symptoms. And if you block those signals, and one of those ways of doing that is through these neurokinin antagonists, which antagonize the receptors of these nerves, then that can have a significant impact on hot flushes and sweats. Doesn't, as far as we can tell, have the wider benefits of hormone therapy, but for those women with severe symptoms, I think this is going to be something really effective, up there with HRT, with the latest one that we're looking at.
So a real alternative.
Absolutely. And in fact, if there's somebody out there that would like to volunteer for our studies, then we'd be happy to hear from them.
You heard it there. If you would like to volunteer,
I can pass on the details for your website.
Absolutely, I'm very happy to share those, and I'm sure there are several groups that we could share that with if you're looking for.
And we're forever striving to fine-tune our hormone therapy to make it even more effective, even less side effects and risks. And in fact, we're going to be looking at a new type of estrogen as well, called estetrol, which is derived from the fetal liver. No fetuses were harmed in its formation, which in preliminary data suggests that it reduces the risk of breast cancer. So that's a study that's probably going to be starting in the new year, in 2020. So yeah.
Interesting. So I've got about 5 minutes left of his time, and I know a lot of you will want to know. Could you talk a little bit about vaginal estrogens?
Sure.
Particularly for that group of women that we were speaking about, who maybe have been told, no, you can't have that either.
Of course. So it's typically in women who've had a hormone receptor positive tumour,
yes,
although a contraindication would also be somebody with a previous thrombosis.
Yeah.
And I can be reassuring on both those counts in the sense that women who've had hormone receptor positive tumour but are on tamoxifen, again, what we call off-label or off-license, we as specialists do prescribe in those situations if there are intractable symptoms that haven't resolved from using vaginal moisturisers and lubricants, etc., etc. And in women with thrombosis, again, because the absorption of these local estrogen pessaries and creams, etc., is so low, and it doesn't go through the liver, we don't believe it increases the risk of clotting, so we're happy to prescribe in those situations. The one situation which is a bit controversial and we wouldn't normally prescribe is for the women with breast cancer who are on aromatase inhibitors.
Yeah.
Again, because the rationale is that you reduce the levels down to sort of zero. And in those situations where there are severe debilitating symptoms, the symptoms can be very bad indeed, that's where some consideration is being given to switching them back to tamoxifen, for instance, rather than continuing with the aromatase inhibitor. Again, we should not put sort of arbitrary rules on whether we prescribe or don't prescribe in most of these situations. If there are severe symptoms, which can be very debilitating, day to day, as well as interfering with intercourse, etc., then don't suffer in silence. Go and see your doctor and get referred to a specialist clinic.
Okay, so as you said, Nick, we don't have a huge amount of NHS menopause specialist clinics in the UK. I think we've got about 40 something at the moment. So we do have quite a lot of women who find that they don't actually have one in their area. Now, I certainly know that women from sort of around the country, in particular instances, can be referred into London clinics. Are you aware, you might not be able to answer this question, are you aware if a woman is in a different part of the country, if, let's say, she's in the northwest, and there's nothing there, if she can be referred into another area for, particularly if we're talking about... She
can be. It may have to go to the commissioning group, the CCG, for a decision.
Okay.
But usually, if there isn't a clinic within the area, they can be referred out of area. And in fact, at our clinics here at Queen Charlotte's and at Chelsea and Westminster, we do see many women out of area, particularly for the very sort of high-risk patients that perhaps, even the sort of secondary care clinic might still feel ambivalent about prescribing. They might refer her on to a tertiary level clinic.
Okay, so the advice would be at least to ask for a referral.
Yeah, absolutely.
Because what we often hear is...
And if you get a closed door from one doctor, don't necessarily just stop there, go to another one. Yeah,
okay, great. Okay, so I'm kind of nearly out of my half an hour of time. I know that you are going to have hundreds of questions. There is a whole raft more of things that I want to ask Nick about. I'm actually going to see him again on Saturday because for anybody who is struggling with POI, premature ovarian insufficiency, or knows somebody, the excellent Daisy Network are having their conference on Saturday, where both Nick and I will be speaking. So there's lots I want to ask him about that. There's loads I want to ask him about PMDD and all sorts of other things. And before we sat down, he very kindly said that at some point in the future we could do something again. So I hope this has been helpful. Nick, if somebody wants to come and see you or one of your colleagues, either via the NHS or privately,
Yes.
obviously you're here at Queen Charlotte's, you're also at the Chelsea in Westminster.
Correct.
And you have a clinic in Harley Street with colleagues, is that correct?
That's right. So we would need a referral letter from the GP for our clinics either here at Queen Charlotte's or at Chelsea and Westminster. For the private clinic,
Can people refer
have a
in?
look at hormonehealth.co.uk. They can self-refer. In fact, over a third of our patients are self-refer.
Right.
Because I can't do it all myself, I actually have 9 associates working with me now. Including an excellent dietitian as well, Nigel Denby.
I know Nigel.
Yeah, and GPs, gynaecologists, all with a menopause qualification working according to British and International Menopause Society guidelines.
Perfect, so that's hormonehealth.co.uk.
Yes.
Perfect. So I hope that's been really helpful to you. As ever, drop a comment below the video. And as you know, sort of Nick has kindly offered to give us some more of his time in the future. I will certainly take that up on your behalf. So Nick, honestly, can't thank you enough.
Well, it's been a great pleasure.
It's been fantastic.
I'm very happy to do this.
I'm so happy to have caught you for half an hour. So as I say, I hope that's helpful. As ever, menopausesupport.co.uk or the Facebook support group, the Menopause Support Network. I will see you somewhere else next time, and hope you've enjoyed it.